brain tumors. It's a more general topic that we haven't actually covered in the last 10 years of these support group meetings, but I thought it would be a appropriate topic. My partner, Dr. Amit Prasad, has put together a good presentation that we're going to use today to go over the nuances of meningiomas. So meningiomas are actually very common brain tumors. In fact, they are one of the most common types of brain tumors that we see. And so in a typical year at our program, we might see 150 to 200 patients with meningiomas. They're fairly run-of-the-mill type of tumors in terms of frequency, but as we see, there's going to be a number of differences between meningiomas, meaning they're not all uniformly the same. They're not all managed the same, so we'll talk about that. We'll also talk about the terminology used in talking about meningiomas, because you'll see this oftentimes in either the physician reports or the radiology reports when it talks about meningiomas. One of the most common terms that you'll see is the term extraaxial, and what that essentially means is that the meningioma is, while it's inside the skull, it's outside of the brain. If something is intraaxial, it'll be within the brain tissue itself. An extraaxial tumor is outside of the brain tissue, but inside of the skull. So where do meningiomas come from? The name meninges is a name given to three thin layers of tissue that are between the bone and the surface of the brain. And the middle layer is called the arachnoid layer, and there's some cells there called arachnoid cap cells that are the origin of meningiomas. So because the arachnoid is very close to the inner lining of the skull, that's the reason why most of these meningiomas are attached to bone, either at the lateral edge of the skull or the skull base or the top of the skull. Meningiomas can occur rarely in regions outside of the skull, as long as arachnoid cap cell layer is present. So about 25 to 30% of brain tumor patients have meningiomas. The other types of tumors besides meningiomas that comprise brain tumors are, for the most part, malignant tumors. So meningioma is a preferable tumor to have if you have to have a brain tumor compared to the other types of tumors. And about 1 in 1,000 people have meningiomas if you happen to just look at random MRI scans of the brain. In about 10% of patients, we can see multiple meningiomas, and in many of these cases, the meningiomas can be related back to some genetic disorder or genetic syndrome in the case of multiple meningiomas, and I'll show you a couple of examples of those. So the most common syndrome that results in multiple meningiomas is called neurofibromatosis type 2, a lot of times abbreviated just NF2. And as you can see in these pictures here, this is a patient with NF2, and they have multiple meningiomas in their brain. So if you see something like this, we immediately start thinking of syndromes, and these syndromes are typically genetically inherited. So oftentimes you can find multiple patients in a family with these syndromes. So when we talk about meningiomas genetics, as I said, when you get down into the details, the meningiomas are not all the same at the cellular level. So this slide has a lot of abbreviations that we're not going to go into, but it does show that there are genetic differences among meningiomas. So even though two tumors may look the same on the MRI scan, they may have different genetics. Older forms of neuropathology books will use a term, you will use some of the terms that you see here, like a secretory meningioma or clear cell meningioma or meningothelial meningioma. But essentially, those are just terms that correlate to the genetics of the specific subtype of tumors. So meningiomas can occur in lots of different locations of the brain. As I said, wherever those arachnoid cap cells are located, you can get a meningioma. So the location is probably the number one factor in determining clinical symptoms, because if the meningioma is close to a critical area of the brain, such as language function or strength or vision, you can develop neurologic symptoms when the tumor is fairly small. If the meningioma is located in a non-critical area of the brain, such as the frontal lobe, the tumor can get quite large before causing symptoms, because while it is pushing on the brain in that specific location, if that location has no function, that pressure on the brain doesn't translate to any specific neurologic deficit. In terms of typical locations, this slide here shows some of the more common locations for meningiomas, and typically neurosurgeons are not super complex when it comes to naming tumors. We typically just name tumors off of the bones for which they originate. So if we have a tumor here that's on the sphenoid bone, we will call it a sphenoid meningioma or sphenoid wing meningioma. If we have a tumor down here at the opening at the base of the skull called the foramen magnum, we call that a foramen magnum meningioma. If we have a tumor that's located along the cerebellar pontine angle here, we call it a cerebellar pontine angle meningioma. And so you can see we just label these meningiomas based on location. That's typically how neurosurgeons call these. And so when you're talking, when one physician is talking to another physician, they talk about a convexity meningioma, we all know that that's a tumor along the convexity of the bone laterally here. So radiographically, meningiomas have a variety of presentations. We'll talk about some of them here. You'll see in this first image over here on the far left upper corner, this is a CT scan, and the CT scan often shows meningiomas as a dense mass there. There's some calcification in this meningioma, which is a common finding. It means the meningioma has typically been around a long time, and part of the tumor has essentially fossilized into bone. So that's something we typically see with meningiomas. When we look at MRI scans, we can also look at meningiomas, and when the MRI is a non-contrast MRI, the meningioma can blend in with the same color as the brain. And so this is the same patient with before and after contrast, and you can see the contrast makes the meningioma stick out very well. In the upper right corner, we can see meningiomas often have a very rich blood supply, and you can actually see these blood vessels going through the tumor. There's a artery, a very common artery that supplies these tumors in the frontal region called the middle meningeal artery, and you can see that coming in right here and providing branches to the tumor. The bottom shows a couple of convexity meningiomas of various sizes. You can see on the bottom right, as the tumor gets larger, it puts pressure on the brain and is distorting the brain. And so this patient could develop symptoms such as headaches or progressive neurologic deficits. A couple more images. Again, meningiomas can have all different forms of shapes and appearances, but typically they have a couple of common elements. The first is they are growing along a bone, so you can almost always typically find a bone edge where a meningioma grows along. They often have what's called a dural tail, which is a area of enhancement that extends a little bit past the meningioma. This might be a dural tail up here going toward the sella. And sometimes they have what's called a CSF cleft, which is a tiny little crevice between the tumor and the brain, in which there's some of that cerebral spinal fluid present. So that's a common finding also among meningiomas. So in this graphic here, we have the various brain tumors placed on the grid, depending upon whether they're benign or malignant, and depending upon whether they're a primary or secondary tumor. And so let's first talk about the definitions. A primary tumor is a tumor that starts in the brain. A secondary tumor is a tumor that starts somewhere else in the body and travels to the brain. So a meningioma is a primary brain tumor. It starts in the brain, but a breast metastasis or a tumor from breast cancer starts outside of the brain and then travels up to the brain, which makes it a secondary tumor. On the vertical scale between benign and malignant, we can see that meningiomas can run the spectrum here. Most meningiomas are benign. About 80 to 90% are benign, and about only 1 or 2% are considered malignant, and another 10% in between. But you can see, just because you see a meningioma on an MRI scan doesn't automatically guarantee you that you have a benign tumor. There's a good chance and good probability that it's a benign tumor, because 80 to 85% of them are benign. But until you get tissue, you cannot specifically rule out a malignant meningioma. There are some instances where on MRI scans, we see what looks like to be a meningioma growing very rapidly, more rapid than typical, and that may give you some sense that maybe you're further up here on the malignant end of the spectrum. But it's really getting tissue and having the pathologist look at it under the microscope that allows you to determine benign versus malignancy for a meningioma. The most common kind of grading system that we use for meningiomas is a 1, 2, 3 grading system. As I said, neurosurgeons are not complex. We just go with the basic stuff. So 1 is a benign tumor. It means the tumor cells are not replicating very quickly. They're growing slowly. So the tumor will increase in size, but the increase will be gradual. Because the increase is gradual, it doesn't typically cause a lot of irritation to the brain, and it also allows the brain to adjust and accommodate, and you can have a meningioma get to a fairly large size before it's discovered. In the middle slide, we have what's called a grade 2 meningioma. These are growing at a medium speed rate, and because they're growing quicker than the grade 1 meningiomas, there can often be some brain irritation, and you can see some of this white, this is fluid or edema in the normal brain around the tumor. And then finally, you can have what's called a grade 3 meningioma. These are tumors that are growing very fast. A large percentage of the tumor cells are actively replicating at any given time. And these tumors, in addition to surgery, need to have radiation treatment as well to achieve control of the tumor. So if you take the tumor out and you provide it to the neuropathologist to review, they do a variety of stains on the specimen, and they look at the different cells in the specimen, and this allows them to classify the tumor as a meningioma. The various different appearances here go back to that slide where we were talking about the various different subtypes of meningiomas, like the clear cell or the meningothelial meningiomas. Those are all able to be identified separately once you have a pathology specimen. So when we grade meningiomas on the scale of 1, 2, or 3, it does give us some predictive value. So grade 1 meningiomas that are very slow growing with appropriate treatment, achieving long-term control is high, and patients often do well for a longer period of time. As you would surmise, as the different meningiomas grades become more aggressive, the rate at which the tumor can recur is higher. So we're talking about a grade 3 meningioma. You can see that it grows back more quickly, and patients are more likely to have a recurrence sooner. So what other tumors can look like a meningioma? As I said, meningiomas are very common. So if you see a tumor that's in a typical location for a meningioma and has a typical shape and appearance of a meningioma, that's a good option to bet on if you're trying to play probability and statistics. But there are a number of other types of tumors that can mimic a meningioma, meaning having the same radiographic appearance of a meningioma. The tumors that are called hemangiopericytomas or solitary fibrous tumors these can look almost identical to meningioma with absolutely no difference in appearance at all. And oftentimes the only way to tell the difference is for the tumor to be treated with surgery, and then the pathologist will tell you what they saw on the specimen. So these can look exactly like a meningioma. They're quite rare though, so you're much more likely to have a meningioma than have a hemangiopericytoma or a solitary fibrous tumor. Schwannomas can look like meningiomas. They grow around the edges of the skull as well. With the latest generation MRI scans and getting very thin slices, we're getting pretty good at differentiating between schwannomas and meningiomas, but often the two get linked hand in hand when you're coming up with a list of possible tumor types. And then finally, there are some malignant tumors, metastatic tumors, like this one down in the bottom right corner here, where it looks like it's coming from the bone because there's a very flat base here rising from the bone, but it's really a metastatic tumor that came from somewhere in the body, such as a lung tumor or colon cancer or even melanoma. So the MRIs are very good at helping us discern between the tumor types, but they're not 100% foolproof. So for meningiomas, there's everything really is going to be personalized here. So when we talk about these treatments, these are very generalized treatments, treatment recommendations. And it's really, you need to look at the MRI scan for each individual patient to come up with the optimal recommendations. So if the tumor is small and the patient, particularly if they're advanced in age and they're not having any problems, it does make sense to consider observation. This does involve obtaining periodic MRI scans for the patient, but it means you're watching it to make sure there's no changes. Now, if there are changes, that would argue to potentially treat the tumor. But generally, observation is a feasible option for small meningiomas that are not causing symptoms in patients that are older. If you have a larger tumor or you're having symptoms or you're concerned about pathology, then surgery is the mainstay of treatment. Surgery immediately removes the mass. The pathologist can confirm whether it's a meningioma or one of those mimics that we just covered. And even if it is a meningioma, the pathologist will tell you, are you dealing with a grade 1 benign tumor or a grade 3 more malignant meningioma? Radiosurgery, also called stereotactic radiosurgery, is using focused beams of radiation to treat meningiomas. At Stanford, we use a machine called the CyberKnife, which is one of a number of machines that can be used to deliver this focused radiation. The advantage of radiosurgery, it's an outpatient, non-invasive treatment and doesn't require any open surgery. And meningiomas are one of the most common types of tumors that we treat with radiosurgery. But again, it depends on the size, shape, location, and clinical symptoms to determine really what should go to radiation treatment. And then the last option is a combination of treatments. There are some situations where you have either a large meningioma that needs several different stages of treatment, or if a patient has multiple meningiomas, you may need to combine some treatments to manage the tumor. So for small tumors such as this little one here, if this is the patient's first scan and it was an incidental finding, the patient was having symptoms like dizziness or something completely unrelated to this, it may make sense to have the patient come back in 6 months with another MRI scan just to see if things are changing. Oftentimes, these tumors don't necessarily grow very quickly, but they are tumors, and so over the longer run, it's not uncommon for these to show progression over time. So observing the tumor runs the risk that the tumor grows while you're watching it. Now, in terms of the tumors that we treat with surgical resection, this little graphic shows how we typically do it. You need to remove the bone to expose the tumor, and so we cut out a bone flap that is replaced at the end of the procedure. So it's like a manhole cover that you temporarily remove. Once the bone is open, it allows you to see inside the skull, and then you can use a series of micro instruments to carefully remove the meningioma and take it out. If you have very complex skull-based meningiomas, there's a number of nerves and blood vessels that you need to avoid. And so some of these surgeries of the skull base can take all day to do. A easy meningioma, it may be a 90 to 90-minute case, maybe a 2-hour case. Surgery immediately removes the mass and eliminates any pressure. So in the upper slide here, we see a patient presenting with a meningioma. It's a little bit hard to see, but there's a little bit of darker gray here that represents some swelling, and the tumor is right under the bone, so it's an easy tumor to resect. This is another tumor. This is in the left frontal lobe. Again, you can see some a little bit darker gray halo around the tumor, and then it's resected and with a good result. So that's an example of surgery. Radiosurgery uses a number of highly focused beams of radiation to treat the tumor. So on a high-speed computer with special software, we contour the tumor and we plan the doses of radiation. So this is an example of a typical CyberKnife machine. The patient will lie on the table here during the treatment, and the machine will move around the patient. It doesn't ever touch the patient or anything like that, but it moves around the patient. It stops at various different locations to deliver a small beam of radiation to the tumor. And so a series of 100 to 120 beams come in from many different angles, all to focus the radiation on the tumor. And the CyberKnife is able to deliver radiation with less than a millimeter of targeting error, so about 1/50th of an inch. So it's highly accurate, very good results overall in terms of controlling meningiomas. So the tumor that we're seeing here, the control rate for a tumor such as this would be in the 93 to 95% chance that the radiation treatment would take care of the tumor for this patient's lifetime. There's a number of situations where you would want to consider multiple strategies. This is a patient I took care of several years ago, where you could see on their scan they have multiple meningiomas. So they have this large meningioma in the midline here. They have a couple of smaller meningiomas down around the frontal region. They have a skull-based meningioma on the right clinoidal region. They have another small meningioma along the floor of the middle fossa, and they have this other meningioma at the base of the skull of the foramen magnum. So, you can see right here, there's like 5 or 6 different meningiomas in a younger patient that is, going to need treatment. At the time she was treated, this patient was around 40 years old. So large number of tumors in a young patient. So how did we manage this? So the first tumor at the top here, we took out with surgery. You can see it's completely gone. And my strategy here was to start with the largest tumor, the one that was the most symptomatic. And work our way to the smaller, less symptomatic tumors. So the first surgery was this. We got the tumor out, and she did well. Then we went down to the frontal region. There were two tumors down in the right frontal region. They were also removed with surgery. Then we were looking at the tumors along the base of the skull. So this anterior clinoid tumor and the tumor in the tentorial bone, and the temporal bone. And because these were skull-based lesions and they were smaller, we treated them with the radiation. You know, at this point, the patient already had 2 surgeries, so we wanted to limit any additional surgery. So we treated these tumors with radiation, and the additional skull-based tumors we treated with radiation as well. So this patient got essentially, you know, a total of 2 surgeries and 2 radiation treatments to cover all the tumors. But at the end of the day, the patient had all the meningiomas treated and has done well. So last slide before we can switch over to questions. This is kind of a generalized chart how we would manage a meningioma patient. And again, before we walk through this chart, I do want to say that every meningioma patient, you need to individualize treatment recommendations. So this is not necessarily a one-size-fits-all. You need to understand the size, shape, and location of the tumor on the patient's MRI scan, and personalize the treatment. So, you know, for when we get to the question and answer part, if you have specifics about your meningioma, we'll do our best to answer it. But realistically, the only way I'm going to be able to give a very specific answers to have an opportunity to take a look at your films. So this flow chart here, what we do is when we have a patient with a meningioma, if the tumor is large and they're symptomatic, it's clear they're going to need surgery. And then we go down this chart here. If the surgery is low risk, we take out the whole tumor. This is a gross total resection. And then we put the patient in what's called observation mode. They get periodic MRI scans. If they come in and they have a small meningioma and they're not symptomatic, we can go straight to observation and not worry about treating until they become symptomatic. If they come in and they're not symptomatic, but we're worried about the location of the tumor, the size, or maybe we're worried about them potentially becoming symptomatic, it may make sense for them to be treated with the radiation, the stereotactic radiosurgery up front. And likewise, if a patient comes in with a larger tumor, needs treatment, but is high risk for surgery, let's say they has a cardiac disease or pulmonary disease, or just not a good candidate for general anesthesia, then oftentimes we'll take the patient to radiation as well. Okay, so I'm gonna stop there and just go to the questions. There's been about 9 or 10 that have come in so far. So I'll try to address the questions in the order in which they've come in. Let's see. Okay. So the first question, thanks for hosting the support group. Glad you guys can participate. And we know it's in the evenings, and depending what time zone you're in, it can be later than the 5:30 that we're in. But you know, we do this as a service for all of you patients with meningiomas, and thank you for attending. The next questions, can the slide be shared after? We're actually going to be putting it onto our YouTube channel, so you can have access to the presentation, the slides, perpetually through that channel. Okay, the next next question talks about, they give a little bit of history. So let me just take a read of this. Okay, so the patient has about a 1 centimeter by 1 centimeter meningioma down around the upper spinal cord. So this is where the spinal cord exits the skull and travels down through the spinal column. The spinal column is a tube of bone, for which the spinal cord runs, and so it's not a very wide tube, and so a meningioma in the spinal canal doesn't have to be very large before it can be causing problems. So this particular MRI scan talks about the spinal cord being displaced, and the cross-sectional area of the spinal canal, which used to be completely available for the spinal cord, is now distorted. It's like an hourglass shape where the tumor is located. It's really pinching on the spinal cord. So the patient said they're not having any problems now, but it's not something that you really want to sit on. When you're dealing with the brain and the spine, it's generally not a good idea to wait for a lot of problems to occur and then try to dig yourself out of that hole, because the neurologic system, unlike other organs, is not as forgiving and coming back from issues. So in this particular case, again, it's very hard to make recommendations without seeing the actual images. But I would be concerned, given the pressure on the spinal cord, that surgery is typically the standard recommendation for this. The reason is that radiation can cause a tumor to temporarily swell. And if it's already compressing the spinal cord, if the tumor were to become inflamed and swollen after radiation, you could have some pretty significant spinal cord issues. So again, not having the images, it's the typical answer for this situation is surgery. And in terms of how complex the spine surgery is, like whether you'll need a fusion or not, that's going to depend upon where the spinal cord is relative to the tumor. And again, it'd be depending upon the MRI scans. The last question for this particular case was whether or not you can, just looking at the scans, can you get an idea of pathology type? Are we talking about a grade 1 or grade 2 or grade 3 meningioma? You can't necessarily do that looking at MRI scans unless you know how fast the tumor is growing. If you have a tumor, as I said, that's growing fairly quickly, it's more likely to be a higher grade tumor. The next question, is there a copy of the recording? Yes, it'll be on the YouTube channel for everybody to take a look at. The next question, is there data on younger patients' long-term outcomes? So there's been actually quite a bit of data on outcomes for meningiomas for a number of decades, because these are very common tumors. So even people in the 1950s, 1960s, the neurosurgeons back then had access to lots of meningioma patients and could follow them and see. What we know is that the grade of the tumor, grade 1, 2, 3, goes a long way to predicting outcomes. The extent of resection, getting all the tumor out versus getting only part of the tumor out, affects outcome. And we mentioned it briefly, but didn't go into a kind of the hybrid or combination therapies. But sometimes there is an advantage of combining the different treatments, meaning removing part of the tumor with surgery and then treating the remaining part of the meningioma with radiation. And an example when you might do something like that would be a large tumor that's putting pressure on the brain and causing symptoms for the patient, but part of that tumor is stuck to some very critical, important structures. So in that situation, you could propose doing a 90% resection of the meningioma to get the pressure off the brain, and then treating the remaining 10% of the tumor that's stuck to very critical structures with the focused stereotactic radiosurgery. So sometimes mixing and combining the therapies is a better option or safer option than trying to do all one or all the other. Another question is, does the lobulation of the tumor indicate the grade of the meningioma prior to surgery? So some of the tumors are round, like a ping pong ball, very smooth. Others are bumpy, like a raspberry or something like that. And the lobulation of the tumor doesn't necessarily correlate with grade of the tumor. So you can't really bank too much on the lobulation telling you what's going on with the tumor. Next question is, does a 5 by 4 centimeter posterior fossa tumor need to be removed in a 55-year-old? The posterior fossa is the area of the brain that's behind the head. It's kind of the area of the brain behind and inferior to your two ears. It's not a very big compartment, and a 5 by 4 centimeter tumor would be occupying quite a large percentage of the posterior fossa, at least a third or so, with significant compression of the brain, and I'm sure likely some edema. So even if you're not having a lot of symptoms, a tumor that size in the posterior fossa would be worrisome. So you're talking about a 2 by 1.5 inch tumor in a small place. And in terms of the risk of like developing any kind of weakness or paralysis, again, that depends on the MRI scan. But in this case, even with a 5 by 4 centimeter posterior fossa tumor, if at larger academic centers or centers with a lot of experience like ours, this should be a low risk procedure. And when you're dealing with meningiomas, because they're benign lesions, in general, you want low risk procedures because you should have a normal lifespan if the tumor's treated appropriately. And so you don't want to take a lot of high risk or take morbidity and develop symptoms and try to manage the meningioma if you don't need to. Does stereotactic radiosurgery cause other brain tumors or cancers to form? And it's a good question, because stereotactic radiosurgery is radiation, and we always associate radiation with maybe causing tumors or cancer. So the first thing to keep in mind is that stereotactic radiosurgery is highly focused radiation. When you're talking about radiation that causes other types of tumors or cancer, that tends to be very non-specific, non-focused radiation. So if you had radiation, exposed to your entire head, that has some chance of down the line of causing tumors to develop, but even that risk is very low. It's typically quoted to be 0.1% per decade. So in over a 50-year period, even if your whole head was exposed to radiation, you should have 0.5% chance of developing malignancy. And what I think people don't realize is the overall risk of developing malignancy with radiosurgery is so low, let's say 1 in 20,000, 1 in 50,000 per patient, that there are multiple other things that people are exposed to every day that carry a higher risk than that. Breast cancer is about 1 in 8 to 1 in 10 in women, and prostate cancer is 1 in 10. Dying in a car accident is 1 in 700 per year. So really per decade. So really the question is, do we worry about something that's 1 in 25,000 in your lifetime when there's a lot of other things that people are doing or people are exposed to that carry a higher risk? So in general, we typically don't worry about this 1 in 25, 1 in 50,000 risk when we're treating meningiomas, because there's a lot of other things that are higher threats to your health. Let's see. Somebody had a question about smell after meningiomas. So meningiomas, if they're located in the frontal region, they can be pushing on what's called the olfactory nerve. These are nerves that are affiliated with smell. And so sometimes patients can have an altered sense of smell, which then also translates to an altered sense of taste. And that can sometimes be frustrating to patients because things don't taste as you would expect them to taste. Next question regarding multiple meningiomas. Do you think they arise from the same cell line, or are they different tumors? How do you manage multiple tumors? So this, as I've been saying, how meningioma treatment is very personalized medicine. When you're dealing with multiple meningiomas, you're dealing with the kind of the ultimate personalized medicine, because in that one case where I showed where the patient ended up having 4 treatments, um, you really have to kind of come up with a strategy to treat the whole package before you embark on the first tumor, because you don't want to end up treating 1 or 2 out of 5 meningiomas and then not have a plan for the rest. So I like to have a plan for the whole thing. In general, you can't say that 2 meningiomas in different parts of the brain are exactly the same or clonal structures of one another. In fact, more likely they're not going to be. But how you approach managing multiple meningiomas, again, depends on size, shape, and location. Typically, I start with the more symptomatic tumor first, and that usually is the largest tumor, and then kind of work our way down over time to the smaller tumors in which the treatment is going to be largely preventative. Couple more questions. Tumor and my meningioma removed 20 years ago, had surgery and radiation, just diagnosed with a meningioma in the same area. So the thought is that the radiation caused it. So despite that theory, I was treated with radiation. So how do you reconcile treating a tumor meningioma with radiation when we think radiation might have caused it in the first place? So yeah, so radiation can cause, as we said, can cause tumor cells to develop. The risk is very low over time, and so it's a statistical probability game that you're playing with this. Generally, the radiation that kills cells is radiation above a certain threshold dose, and radiation that potentially induces tumor is a lower dose. So in the case, if this was a radiation-induced meningioma, and it's going to be hard to prove that it was, even if it's in the same location, but if it's a radiation-induced meningioma, it would have grown because it was exposed to a low dose of radiation, and then it was killed by being exposed to a high dose of radiation. So that's how you would kind of reconcile that. The next question is, when do you recommend genetic testing to determine NF2? So there's no hard and fast rules here. NF2 has a series of clinical and physical exam findings. So in addition to multiple meningiomas, NF2 patient will have acoustic neuromas, typically bilateral acoustic neuromas, which are benign tumors on the balance nerve that impact hearing. NF patients can also have tumors in their spine as well. So if I see a patient with multiple meningiomas, particularly if they're young, on the younger side, it may be worth getting a genetic test done to see if there are certain genetic markers that patient is carrying that predisposes them for multiple meningiomas. Obviously, this is more important in families where one of the older generations has multiple meningiomas, and you're trying to determine whether or not to screen with MRI scans the younger generation. And it's a little bit of a challenge because you're just those patients feel well. You're just putting them in the MRI scanner because of a relative having a tumor. So there's a lot of work and resources thrown at it, often to find that the majority of scans are negative. So in principle, if you have a younger patient, younger than the age of 30 or 35 with multiple meningiomas, it's probably worth some genetic testing. If it's an older patient, the older they get, the less likely it's going to be a genetic issue that they were exposed to. So next question, gamma knife radiation for meningioma, how does it compare to gamma knife or CyberKnife? That's a great question. They're actually, the machines have the same accuracy, this about 0.5 millimeter of targeting error. Both machines, you dial in the dose of radiation that you want to use. So for either the gamma knife or the CyberKnife, you could select the dose of radiation and enter it in. So essentially what the tumor sees is a very specifically set dose of radiation, but it doesn't know the source of the radiation. So I typically explain the difference to my patients by saying, if you're let's say we're trying to hard boil some eggs in boiling water and you're the egg inside the pot, all you see is a specific temperature of boiling water. You don't see if it's gas or electric heating source on the outside, or even, a wood fire heating source. You just see a specific temperature. And that's what the meningiomas see. They just see a dose of radiation that is pre-dialed into the software by the neurosurgeon. And it doesn't know if that radiation is coming from a gamma knife or a cyber knife or some other machine. All it sees is a specific dose, and if that dose is sufficient to kill the tumor, then that's all it needs to have happen. Okay, I think we got through all the questions, and I think we're getting close to the completion of our time. So did want to thank everybody again for joining the support group. There's one last question that came in. I'll answer this one before we go. Accuracy in between the gamma knife and the cyber knife, no difference in accuracy. Both are sub-millimeter accuracy machines. So again, thanks everybody for participating in second quarter 2024 meningioma patient support group. I have my email and phone number on the last slide if anybody has follow-up questions or wants to actually send films. We're happy to take a look and render more specific opinions than I could tonight. Have a great evening, everybody.